Testing, testing, testing.
Can hear you
It
really
sounds
well.
good
But
in here, Matt.
hardly.
Testing, testing. Oh, can you hear me okay, Ozzy?
Yes.
Okay, great.
All right, we'll go ahead and get started. So I have the distinct pleasure of introducing Dr. Ackerman for today's Grand Rounds. Dr. Ackerman is the Windland Smith Rice Cardiovascular Genomics Research Professor and Professor of Medicine, Pediatrics, and Pharmacology at Mayo in Rochester. Dr. Ackerman received both MD and PhD from the Alex School of Medicine at Mayo Clinic. And then he stayed on to do a fellowship or a residency in pediatrics and fellowship in pediatric cardiology. He's currently the director of the Windland Smith Rice Genetic Heart Rhythm Clinic and the Sudden Death Genomics Laboratory. We'd be here about 20 minutes if we tried to read the titles of the 700 peer-reviewed papers that he's published. I think we'll skip that part. He has served as the president of SADS. So for those of you that aren't in cardiology, that's a sudden arrhythmic death support group for families and researchers interested in that arena. In 2015, he was named the Mayo Clinic's Distinguished Clinician. In 2018, he was named the Pediatric Investigator Award and Distinguished Scientist Award from Heart Rhythm Society. That is the equivalent of the ACC or the AHA for all of us EP people. His name was in the press a little bit more contemporarily in around the pandemic because when college conferences and sports teams wanted advice on how to safely return to play, this is the guy that they call. So we are extremely fortunate to have Dr. Ackerman here speaking to us. He is one of the original proponents of really precision medicine and not a one size or one recommendation fits all. And so I'm very excited to have him here to speak to us today.
Thanks a lot, Andy, and thanks so much with you and Vinny. Where's Vinny? Oh, he's okay. Hi, Vinny. Great to get to be with you for Grand. I've been looking forward to this. I had this epiphany after our daughter graduated from high school 4 years ago that I would spend 3 weeks on Mayo Clinic Florida's campus in Jacksonville in February, and then 3 weeks on Mayo's Arizona campus in March. And all of a sudden, life is way better. And so I wish my daughter would have graduated sooner. But I love this topic. I hope you'll enjoy it as I know I'm going to. And here's your CME code. Make sure you get your credits. Those joining online, have fun. I'm going to challenge you to actually join us because I know what we do when we connect online. And so those of you who are in the shower, finish up. Make sure you stay on mute and all of those things that we do in the virtual world. Who says they can't play anyway? I'm conflicted. These are my conflicts of interest that I disclose. They're not going to affect our ability. You can be judge and jury of this, but they're not. They're not going to affect our ability to do this well. And this well, I hope, will be an assessment of the past and present guidelines. We're not going to read them. We can read, so we won't look at them. But I really want to then turn and examine the data that has catalyzed this 30-year evolution, I would say, from a posture of disqualification to a posture of let's talk about it. Let's see what we can do. And when it comes to an athlete with sudden cardiac death predisposing, GHD is genetic heart disease, I want to kind of get a sense of how we're wired, just what our intrinsic knee-jerk reaction would be. Would you allow an athlete with one of these conditions, and you could fill in the blank, long QT, Brugada, hypertrophic cardiomyopathy, I really don't care, and a prior on the field faint? You didn't like the faint, but the faint occurred while untreated, undiagnosed, and ultimately you diagnose, you treat. Would you allow him or her to return to the field, to return to his competitive sport? And let's be bold. Those who are yes, who would say, yeah, I would? Okay, I'm feeling a little bit lonely. Those who say no way. Okay. And those who, as we say in the Midwest, are chicken. No, the maybe. Okay, who are the maybe? Well, good. What my challenge for you is, if you are no, I want to get you to maybe. If you are maybe, I want you to be willing to entertain yes. And if you're quickly a yes person, I want you to be very careful. And I'll explain why. Now, this issue of sudden death in an athlete, it feels like it's a huge problem, but it pales, doesn't it, in comparison? 500 to 1,000 people, mostly elderly, will die suddenly today. And it's not anywhere near car accident related sudden deaths. Back in the day, H1N1, 3,000 infants will not reach his or her first birthday. And so you'd say, but when it's an athlete, it's just like this ginormous wow phenomenon. But really, from an actuarial perspective, it's puny. Less than 100 athletes in the United States die suddenly each year. But when it happens, it kind of grabs the community in a way that car accident deaths just don't. And collectively, your and my risk, by virtue of being young, so by virtue of being young and alive, we have about a 1 in 100,000 chance of dying suddenly each year. Now, if we're at Division I university schools, it's 1 in 80,000. And if we're a Black man playing basketball, it's 1 in 4,000 chance. So it's not a one size fits all in terms of risk. And we have, and the way it's so gripping, and you take back 35 years, probably the first one that comes to mind is Hank Gath, 35 years ago, that started. And sports cardiology might have started shortly after Reggie Lewis's death in 1993. And sort of each year of those 100 athletes who die suddenly, they're sort of the one. And it's basketball, it's football, as in football, world football, also known as soccer, it's hockey, it's every sport, and it's at all ages. It's also white individuals, and it's also females, although there's many more sudden deaths of male athletes each year than female athletes. And so when these happen, there's this reaction like, how did it happen? We can't let this happen again. Was it a known entity? If it was, who let them play? We're going to take them out. And so there's a very punitive posture to this entity of sudden death predisposing heart conditions. And so a year after Reggie Lewis's death, the first guidelines in America came out in 1994, a year after, 31 years ago. And back then, if you were practicing in that day, it was really simple. No. That was the guideline. It was short. It was longer pages, but it really said this: unless your heart is perfect, no competitive sports, period. Done. We then updated it, and this was the we as in I was included for the first time. I joined Mayo Clinic's faculty in 2000. So I'm just 5 years on staff. And it was incredible to think back, how did I get on the guidelines? And I'll show you the how. But we updated it, or back then it was called the Bethesda. And at the same time, so did the Europeans. And this really started the formality of the consensus cardiology statements about sports participation. Now, the cast of characters turns out to be very important because powerful forces in cardiology, and I mean it, powerful, really guided an evidence-less perspective. There was no data. It was sort of opinions. And here I am. Now, why did I get on here? My mentor, Dr. David Driscoll, was my chief. He got me on this document and helped launch my career in this area. Now, if those of you have read these guidelines, here's the aha moment. Do you see it? Look at where we met. So if you've ever looked at those guidelines and said, that doesn't make any sense. Yeah, I wasn't there, but some of them were on Bourbon Street. Okay. And so there's a reason, if you look at this, you say it doesn't make sense. But what we did here is we said, and my contribution is the second part as a genetic cardiologist, unless your heart is perfect or the syndrome is confined to just your genome, you're done. No competitive sports. And then we gave for the first time a carve out. Well, maybe we'll give you a bone. And that bone are the so-called class 1A sports. And so the guidelines read things like this. If you have this lesion, hypertrophic cardiomyopathy, doesn't matter what kind, obstructive, non-obstructive, apical, doesn't matter how you're treated, you're done, except 1A. Or the other cardiomyopathies, you're done, except 1A. Prudence for non-compaction, you're done, except 1A. What did we say for the cardiac channelopathies, which is my main world? Well, we just said, all of you, you're done, except for class 1A sports. And then remember, I told you the Europeans were doing the same thing. So you're going to see this interesting dichotomy getting set up across the pond, where in North America, we said here that you would be done for symptomatic long QT syndrome. Your long QT did something, you're done, except 1A, or hasn't done anything yet, but based upon this ECG cutoff, 470 men, 480 women, you would be done. And then we did the carve out, which turned out to be very difficult to achieve back then, but unbelievably important, because we started to recognize that with the advent of genetic testing, first commercial genetic test for long QT syndrome, circa 2003, that we would be exposing more and more people with positive genetic test only substrates, also known as genotype positive, but phenotype negative. And we said we would give them the okay to play for the most part. So that was, if you will, my contribution. I did not contribute to the class 1A thing, where some of you might be asking yourself, what are those carve-out sports, the 1As? And please tell me that there's something good in there. Actually, no, badminton is too dangerous. You are in trouble for allowing them to do badminton. That was Task Force 8. I was not on Task Force 8, but this group on Bourbon Street spent a lot of time sort of where is my sport in terms of dynamicity on the x-axis, static nature of the sport on the y-axis. And you could look for your favorite sport. Mine was Taekwondo that I did for 30 years, but it doesn't matter, because all you get to do is constrain your eye to the bottom left corner and everything else goes away, because the safe six, and be careful enunciating that, the safe six sports are these. We'll let you do billiards, bowling, cricket, curling, golf, or riflery. And you guess what? Guess who is the most ticked about this 1A? The cricketers. They are so upset. The audacity to put my sport down here in 1A. It at least belongs with ping pong and badminton. So every time they see this, they just like, you're upset, aren't you? Yeah. You know, like, how dare you put that? And yeah, so that's one thing. And then the other thing that I always found problematic with this was, you and I are going to disqualify Sally, Johnny from the sport they love, they've committed themselves to, and then we tell them, go take up a gun. I just didn't want to do that, because that can go very badly. But here's a news flash for you. Guess what? Billiards is no longer on the list. Yeah, it got updated. It was declared too dangerous. And so it's replaced with yoga. So these currently are the safe six for what we'll let them do. And remember the European thing? Guess what they did? They went retro at the same time. They went back to 1994. Their guidelines said nothing, not even cricket. So you wouldn't get to do anything by guidelines. And so we had this dilemma getting set up where in North America, we said, if all you have is positive genetic tests for an HCM mutation, but we can't see the disease, we would let you play. Europeans said, no way. Gene carriers, you're done. You are done. And then we said for long QT syndrome in Europe, symptomatic, asymptomatic, doesn't matter, you're disqualified. And check out their QT thresholds for disqualification. Unbelievable how many they ought to be disqualifying if they actually followed that. That expressed in only your genome carve out that we created back then, they said, forget about that. If you have a positive genetic test, you are disqualified. And so think of this, we're saying you may play if you have what we called concealed long QT syndrome. It's in your genetic code, but we can't see it electrocardiographically. We'd give you the permission to play. European Society said, forget about that. You are done. And think of that. That's incredible. For 20 years now, the European approach has been, and many others in America has been, if you have a positive genetic test all by itself, a whatchamacallit, a thingamabob, a disease-caused variant, you're disqualified from everything you love to do. There better be really good evidence if we're going to be doing that. And here's the evidence. Yeah. There is none. There's none. And so what I called it 20 years ago and still do is that this is genetic discrimination. And we need to call it out as that and say that's not the right way of doing this thing called sports cardiology. Well, 20 years ago, we at least confessed in the guidelines some things. Oh, interesting. Based largely on a randomized trial of 10,000 athletes. No, collective judgments and experiences. And we were invoking what we said was the art of medicine. So I have always wondered when we have disqualified Susie, disqualified Johnny, did we tell the families and the athlete, you know, right now I'm kicking you out and I'm feeling rather artistic in this approach? No, we don't really do that confession. We said, and this will occasionally cause some to be withdrawn from competition unnecessarily, but too bad, so sad, because it's a controllable risk factor. Why is it controllable? How is it controllable? That sports participation permission form that we sign, that's the controllable nature of it. I'm not signing it. And we declared the self-proclaimed wisdom of these recommendations. In other words, if in doubt, kick them out. And although you're going to see soon that the guidelines are changing, this if in doubt, kick them out is still probably the majority posture among many, many practicing cardiologists. Why? I bet it has to do with Task Force 12. Yeah, getting sued. And this takes back to a case almost now 30 years ago, a basketball player, Knapp, at Northwestern University. And we are concerned that what if we allow you to play and things go sideways? Will I get malpractice retribution? And although there's not an example to my knowledge where that has happened, that's the elephant in the room. So for 20 years of my practice, I have been going against the guidelines when I have returned an athlete to his or her sport. But that has now changed. The lawsuit possibility is no longer, why did you let them play? The guideline says you can't. Because guess what? The guidelines don't say that any longer. But this has really, I think, continues to be the elephant in the room. But then about a decade ago, the wind started changing in a different direction. How so? Well, the guidelines started to say things like this, and I was on this document. All long QT patients who wish to engage in sport should see an expert, class 1. Well, why do you need an expert to say you're done? So something was happening in the view of the experts that maybe the disqualification posture was too punitive. And then it all changed a decade ago. New cast of characters leading, still Dr. Zipes and Dr. Marin participating. But for example, the default disqualification for the channelopathies got rescinded. And again, did the evidence change a lot? Well, some, but did the drivers, the influencers, influence the different perspective? That might have been what changed things in this case. What did we say? We said things like, yeah, see an expert. This is going to be complicated. It is not a risk-free proposition. And so you better be well informed. We said that you should be in a penalty box. That what we meant by that, 3 months, we just pulled it out of thin air. But it meant that if you have an athlete who has an on-the-field faint, we need to adopt a concussion-like protocol. You can't get concussed on Friday and play on Saturday. You can't faint on the field on Friday and then be reinstated the next day. There needs to be a pause so that you can be thoroughly evaluated, risk stratified, counseled, treated, and then potentially return. So we arbitrarily said 3 months because it takes time to get in to see somebody. And then we said there's still, remember 2005 genetic code, you're disqualified, 2015, there's still no evidence that the positive genetic test alone is sufficient for a disqualification. And then we said, even for long QT syndrome, even if you've been symptomatic, you may be able to return to play. So check out the 30-year evolution in a slide. From 1994, if in doubt, kick them out, to 20 years ago, unless your heart is perfect or just your genome, then we'll give you cricket, to starting 10 years ago, after you have been well evaluated, well risk stratified, well treated, and well reformed, a return to play may be possible. And guess what? It's not just 2015. As of 2 weeks ago, the new ACC document came out, and I'll summarize about 1,000 pages. It feels like our guidelines has 1,000 pages in it to this. Return to play is possible by guidelines. So those who are disqualifying arbitrarily just because of diagnosis are now officially practicing contrary to guidelines. It's an unbelievable transition we have. In other words, what we advocated for from the very beginning, shared decision-making, is making its way, has made its way formally to sports cardiology. And this feels for some like this is new territory. How did this happen? I want to turn now to the evidence that has helped catalyze it, because our program, for the last 25 years of my faculty career, when I joined the staff, I immediately rejected it. This, if in doubt, kick them out. It just felt wrong. I mean, morally, viscerally wrong. And I felt like, Tom Hanks in one of my favorite movies, Big. Remember that scene in The Office, raising his hand? I don't get it. I don't get it. Why are we doing it that way? That was me at that time. And I thought, why can't we do it this way? Respect patient and family autonomy and their right to make a well-informed decision. After all, it seemed like we were doing that with almost every aspect of medicine. And yet we did this carve out. Yeah, but we can't do it for sports because it's not going to work. And I'll show you some of the myths that we've debunked with this "it can't work" idea. So I still embrace the philosophy. I think this is the correct approach. But over the years, it's been buttressed by data, experience, evidence. And I'll show you some of that, because we felt that we better study this carefully and publish it transparently, because if our athletes that we're supporting his or her return to play are going belly up, we better be reporting this. And then say, well, time out. This is dancing too close to the fire when we're doing this. So one of the things that we have to show is that I don't actually care if my patients are athletes. Most of my patients are not. So you don't come to Mayo Clinic because he only sees athletes. Most of my patients are not athletes. So I don't need to try to make them. I got to get you to be an athlete. No. So most are not, but many are. And of this, our initial experience at the beginning of my career, we immediately saw and were able to debunk a myth that went something like, if you give him or her the chance to return to play, or their mom and dad the chance to choose to return, they will always go back to sport. Not true. So this notion that families can't do shared decision making because they will always go to sport because they've got to do sport. Not true. We saw among these initial athletes that the whole purpose for coming to Mayo and flying all over the country was to get reinstated. They had been disqualified. Their motivation is to return. And yet 1 out of 6 of those athletes and their families disqualified themselves after going through the drill. Now, the majority, 85%, said, yeah, I hear you. I'm still going to be an athlete. This is the sample snapshot of our athlete cohort back then. Most don't have an ICD. Only 15% did. And most, yeah, you won't believe this, they just did not choose 1A sports. That's not what they arrived doing. This is the kind of sports they were doing, and we let them be who they are. Now, we could talk about certain diseases where we might need to modify their sports prescription because their sport training may actually be a disease accelerator for certain genetic heart diseases. But for long QT syndrome, it's not, so we let them be who they were. And if you understand long QT syndrome and about long QT syndrome expressivity greatest in prepubertal boys, we have a cohort that's enriched for events to happen. And we even have the majority, over half, having that version of long QT syndrome, type 1, where we know in the untreated state, adrenaline is the trigger. So it's a real cohort with real measurable risk for potential events. And yet, what was the event rate? Uno. 1 athlete, dose, 2 events in that many athlete years. And were we surprised with his events? Not really. This is his. LQT1, a very long QT interval, cardiac arrest as a kindergartner, and he would go on and have 2 events subsequently, but went on to play collegiate soccer, and he now is an engineer at SpaceX. Doing pretty good. So that was our initial experience, but remember, he was one of the 15% who had a defibrillator. The defibrillator guideline saga was an interesting one happening in parallel. And it said, if you own one of these things, and now we used to say, if you own one of these things, now it's if you own one of these things, because we put them all over the place, doesn't matter. You're disqualified. And that was viewed as an interesting phenomenon among Dr. Rhee and the ICD installers, because when they were surveyed, half didn't agree with this. And wow, who said that? And Dr. Lampert, a good friend of mine and a real trailblazer, she did something back then, almost 20 years ago, that was viewed as kind of anathema. She started an ICD sports registry, and people kind of mocked her and said, Rachel, there's not going to be anybody in it because that's not supposed to be allowed. She said, I think it's going to get full. And so we have about 400 athletes who are following with internal defibrillators. And this has been the experience that we reported. Now, of course, there ought to be events because they got a defibrillator for some reason, hopefully. And you see 13% had at least one appropriate shock. A variety of lesions have gotten represented in our ICD sports registry. And at the time, long QT syndrome was the most, but a good number of the other genetic heart diseases. Now, the idea back then went something like, we can't let you do it. So the guideline writers, meaning have an ICD, be in your sport, because it's going to be dangerous to the athlete and potentially damaging to the device. That was what was put forward. And it turns out that there's zero evidence of that. We have seen no signal of greater danger to the athlete or damage to the device. The rate of device malfunctions, lead fractures, etc., is no higher in our competitive athletes than our sedentary ICD owners. We've updated this, and then you can see collectively we have about a 3% chance per year. So 3 shocks per 100 years is sort of the risk predisposition of our athlete cohort. And then we updated our personal athlete experience in my program. This is one of my PhD students now on staff for Mayo Clinic platform, Carrie. And you can see not 130 athletes, a lot more, and they're starting to come. Why do they start to come? You build it, they'll come, finding a place that says, hey, at least we can have a conversation. So we started to see many athletes disqualified all over the country, particularly for long QT syndrome, but you see a growing number for lesions called not long QT syndrome. And our updated event rate is no longer uno, but we now had 9 athletes have a non-lethal episode, and giving us about a 1% chance. So of my athletes, they have about a 1% chance per year of having a non-lethal event. And this caught our attention. It didn't surprise us. It surprised a lot of people. Guess who has less events? Our athletes compared to our former athletes. And you can imagine and put forward some ideas why, couldn't you? I think it's discipline. Following the drill to the T, because they know that a breakthrough cardiac event is going to put them in a penalty box, is going to cause a whole new round of conversation with mom, dad, athlete, and us, and might result in a different conclusion in that shared decision-making session about your continuation. So they're highly motivated in terms of medication adherence and so forth. So we think that's part of the reason why their event rates are actually the lowest, even though they're engaging in adrenaline-related activities that could potentially be more disease triggering. And then we completed the sojourn with a 20-year review of my practice, thanks to Katie and Marissa. Katie and Marissa are now third-year medical students in Milwaukee, and they looked at all of my athletes over the first 20 years of my career, and we shared what our drill is for how we do it, and we then looked at the collective number of athletes. I currently follow about 800 athletes, but this was as of a few years ago, and you can see the number of events go from 1 athlete to 9 to now 46 have experienced a breakthrough disease-associated cardiac event. And we can start to get event rates so we can be more precise in our counseling session. What is the risk? What is the lay of the land when we're risk stratifying you, when we're treating you, and so forth? The numbers shrink immediately when you try to say, can you tell me what's the risk of my sport? That gets hard, the numbers shrink. We have started to see trends for what is my disease, long QT, CPVT, and so forth. But still, in the first 25 years of my practice, 0 deaths of my return to sport athletes. And we presented this a long time ago at World Congress in South Africa, and I'll never forget this philosopher. There was a female philosopher who was speaking in our session, and she came up to me and she said, your approach is right, It's foundationally right. It's morally right. And when you have your first death of an athlete that you returned, do not change your position. It wasn't if you ever have somebody die, it was when. And that was about 12 years ago. I've never forgotten her words, and it was chilling. And thankfully, that when has still not occurred, but I'm reminded that this is not a zero risk proposition. We've been able to give more granularity thanks to Katie Tolbert, looking at my experience of the 80% who don't have an ICD who we return and the 20% who do have an ICD. And I think it's quite interesting. And I think Dr. Papez and Dr. Ree and others would look at that and say, that's the difference we should have, meaning we're getting better at picking who ought to have a defibrillator, because we started to see a slippery slope creep in among cardiologists, and it went something like this. I won't let you play unless we install a defibrillator. That's wrong. That's dangerous, because you're going to pay the piper for device-related complications if that's sort of the quid pro quo. And so, for example, you can see in long QT syndrome, if I didn't think you have a defibrillator, your event rate is almost zero. If we chose to install a defibrillator, not because you're an athlete, I tell my patients, I'm giving you a defibrillator whether you're an athlete, artist, academic, I don't care. Your disease warrants it. Not because you want to play and I need to be comforted that I've got my backside protected. But when we do it that way, look at the differential in event rates among those who we chose to use an ICD versus not. Well, that's just you guys. You've had a collective experience of 25 years, 800 patients. Will this be generalizable? Well, many programs throughout the country and world joined Rachel Lampert, Charlene Day, and me in a 3-year, 4-year prospective NIH study where we did 2 studies in parallel. People with long QT, people with hypertrophic cardiomyopathy. And I'll just show you the long QT punchline, because we hypothesize that among individuals who exercise the most, not necessarily athletes, exercise the most versus those who were the most sedentary, we would have higher quality of life without more events. That was the hypothesis that we were testing. Many sites, 42 sites across, and we enrolled about 1,400 individuals. And I'll show you the punchline. See the lines? Comparing those who are the most vigorous to those who are the most sedentary. Yeah, there's 2 lines. They just completely overlap. We see no signal of an increased event rate based upon what is your activity level, no matter how we adjudicated it. Meaning the there is not there, this notion that it's going to be more dangerous, which was the whole premise for why we need to find you and why we need to kick you out of those sports. Well, that's just normal people. And your little leaguers, okay, go ahead and let them play. But what about elite? Can we be elite and not be at risk? That was kind of a question posed that's not really fair, is it? Because if our posture has been a 30-year posture of disqualifying, how do you get good at a sport if you haven't been allowed to be in it? So you can see that there is so who would become elite, do you think? And then get found? Those who are asymptomatic, who got screened out and got found. That's how you could have made it through, started Little League hockey at age 3 and gotten good, as opposed to the disease being rearing its head. So I recognize that that could be a biased sampling potential. This was a fun project that we did with Katie Tolbert in the middle between her father, Matt Martinez, and I just had to let them have a Martinez first and last author, even though Katie was in my lab for the year doing this. So Katie joined us. She's now a first-year MD PhD student at Mayo Clinic. But we looked at 4 of the prominent sports cardiology programs to put together enough of our elites. And we define elites as, and you can tell me if this is reasonable, a Division I university athlete or professional athlete. I think that's a pretty good selection. So we had 76 of them playing at the elite level. And again, to that sampling, 2/3 were asymptomatic. So they were, many of them, screened as part of the D1 University ECG and so forth. Most were initially disqualified, and then we, 4 centers, enabled their return to play. And unlike the normal athlete, where I told you 15% will self-disqualify, self-disqualification doesn't happen that much if you've gotten that good. So very few disqualify from within, but it still happens. And our number among the elites is 3 of them. 3 of the 76 have had at least one non-lethal breakthrough event in 200 athlete years. And 5% remain disqualified despite our return to play support. And I'll comment on that issue of it. So we've gone from having the annual tragic face trading card that has been brought to Washington, D.C. for policymaking to a different story where we want our patients, I want my patients to live and thrive despite their diagnosis and to have their dreams limited, their athletic pursuits or whatever their case may be, limited by things like desire, devotion, discipline, determination, and not by the other D, my diagnosis. And so I'll share a few faces of the successes, and I share them with permission because these are public knowledge stories of me being their cardiologist. So Jared Butler was the first to break the glass ceiling at the NBA. The NBA posture was heart condition, NBA, oil and water, doesn't mix, not allowed in our league. He was the first. We formalized what was called a fitness to play panel. And so there's a decision formal process in the NBA, and many of the other professional sports have adopted a similar decision panel. And Jared Butler, who was the most valuable player when Baylor won the men's basketball championship in 2021, was the first. And he was drafted, would have been first round draft, but you can see why. He was drafted second round and joined Utah Jazz, currently plays with the Philadelphia 76ers. The next year, Keontae broke through round number 2, the second athlete permitted in the NBA, and he currently plays for the Charlotte Hornets. And then the third, 2 years later, so we didn't have anybody in draft 2023, but third year, Savannah's son, also known as Bronny, who's my patient, was permitted to play, was approved by this fitness to play panel, and plays for the Los Angeles Lakers. I want you to look at this because there's a dark side to this 30-year disqualification that happens to these families that doesn't get reported. And it's this: what is the phenotype of the disqualified athlete? I can tell you they have a decrease in quality of life. Now, this is bias because I see the families where the mom and dad saw what the disqualification did to their Susie, to their Bobby. And that what they saw, they said, we can't live like this. So the disqualified athlete who after their disqualification, they're like, yeah, I didn't really want to play anyway. This may not be true of them. Okay. So it's a sampling again of the kind of disqualified athletes that I see. They have a decrease in quality of life, dramatically so. They have a decrease in academic performance, certainly. They have increase in mental health issues, increase in alcohol and drug use. I've seen those who became cutters, had suicidal thoughts, suicidal attempts, and completed suicides. Now, that story of what we do when we say, sorry, you're not ever playing again, that never gets covered or commented upon, because instead we say it's prudent to disqualify you. On the other hand, this is the phenotype of my return to play athletes. Over 825 now, 15% disqualify on their own. And when they say they're done, I can guarantee you they get along with life a lot better when they were part of the decision saying, I think it doesn't make sense for me to continue. They get along so much better than when we unilaterally pull the rug out from under them and say, you're done. Their non-lethal event rate is low. Currently, 19% of my athletes have an ICD, and if they do, their event rate is higher. Deaths, as I showed you, remain zero. Quality of life dramatically higher. So when we use this word back in 2005 of prudence, which group would it be more prudent to belong to? I don't know. I'm not trying to trick you. I think I would prefer being in this group. And so I return you to this question as we round the corner and make some concluding thoughts. I don't need you to revote, but I want you to think, have I moved you at all to change your posture? And if you're ready to leave, if in doubt, kick them out and embrace this approach, I want to leave you with 6 critical caveats. The first, for those who are quickly, yes, oh yeah, I'd do that. Am I the right person to be doing this? Because while I might have been at risk for lawsuits for the first 20 years of my career, because every one of my athletes was returned against guidelines. So there might have been vulnerability that some would say, wow, you're taking a big risk. Now it's different because the guidelines are supportive, but that doesn't change the potential that if things go sideways, that there could not be consequence. So just like I should never do a fetal echo, I learned where you're heading. Somebody whispered, and I should never do a transplant evaluation. So not every cardiologist should be doing this session. It is nuanced. It is, so sports cardiology, you have to ask, it's okay to pass the buck and say, I need to refer you. It's not okay to be unqualified to do this session, but disqualify them anyway. That is not acceptable. Second, our requirement is that for our minors, that the athlete and both parents, whenever possible, must be in agreement. If there's a veto vote within the family unit, they're self-disqualified. Third, there can be no covert operations. Well, can we just keep it to ourselves? We'll have the AED around, but don't tell the school, don't tell the coaches. I tell them, you can try that somewhere else. I will not support that. That's not a good formula. The athlete must have the AED as part of their sports gear, non-negotiable. Just like the peanut allergy athlete doesn't rely on somebody else's EpiPen somewhere in the building. We need to have a reliable safe. Now, I insist on that, but I also say it's hard to insist on that when we still have never had an AED rescue shock. Never yet. And then we need to prepare our little leaguer, our middle schooler, our really good varsity level athlete in high school that things could change at the university level. That there's no such thing as shared decision-making at D1. I call it TDM or BDM. It's business decision-making. And it takes on a life of its own. And if you were like, oh yeah, we're going good, and all of a sudden they get their scholarship offered at University X only to have it rescinded, and we never prepared them that the things that you'll need to ask, the permissions that you'll need to get before you sign, and so forth, that is very important. And then document. It's not a zero risk proposition. So make sure you've said things like you could still die, and they're proceeding with eyes wide open. So with those 6 caveats, I'll leave you with a handful of final take-home points to launch us in a few minutes of dialogue. I hope I've showed you that in the past, philosophy and art have trumped science and evidence as the underpinnings of the past guidelines. the evidence is increasing, but it is still a bit artistic. I think second, I hope I've showed you that athletes and their families have the right to know what's the evidence or the lack of evidence that's going in your and my recommendation when we're disqualifying them or when we're requalifying them. Third, I would suggest that the earlier guidelines were not only too strict, but they also hopefully inadvertently advocated genetic discrimination. Make sure you leave knowing that this myth has been fully debunked, that athletes and their families are fully capable to choose to disqualify themselves. And evidence, at least in our program, among those who have chosen to remain an athlete, their disease-triggered event rates have been extremely low. We're continuing to follow this, and if you have an athlete, get them connected to ORCA. This is a national outcomes registry for cardiac conditions in athletes. It's sponsored and headquartered in Seattle, Washington by Jonathan Dresner and Kimberly Harmon. I'm in the core group, and we just opened enrollment to high school athletes as well. So tell them about ORCA. It's easy for them to self-enroll so we can continue to mount experience and evidence as to the risk associated with continuation in their sport. I want to take one moment to thank the entities that have partnered with our program at Mayo Clinic, especially the philanthropic support from Wendy's family that help us to try to fulfill one of our Mayo Clinic brothers' mandates of healing the sick and advancing the science. And thank you for having me as your Grand Round speaker, and I'd love to see what questions this has created. Thanks, everyone. And we'll have Dr. Hartley turn on the thing so that the audience joining online can hear and see what Dr. Perez.
Thanks, Mike. That was an incredible talk and very well received. I'm curious, have you had it occur, and if so, how do you handle it, where a family comes to you, they want to return to play, but they want a psychological safety blanket of an ICD, even if you think that an ICD isn't necessarily warranted? How often have you encountered that, and how do you counsel them?
Yeah, so if you didn't hear online is they want to return, but the family, not the physician, is needing the defibrillator installed for peace of mind, the safety blanket. The honest answer is it depends on how far away are they from an ICD recommendation from you and me. So I'll give you an example. If it's long QT syndrome, asymptomatic, QTC is not even there, I'm not ever going to install a defibrillator for their threshold, for their safety. If it was hypertrophic cardiomyopathy and their wall thickness was 21 millimeters, not 30 millimeters, and they're mutation positive for an MYH7 mutation. Now, the guidelines don't quite have that person, athlete or artist, at an ICD recommendation. But to me, that starts to get close enough. So if that family is saying, I want an ICD, I would not talk them out of it. If they said, what do you think? I say, well, I don't think we're there yet. So there's different closeness to it, but I try very, very much to say, I will never, and the guidelines are pretty strong, and the newest guidelines that just came out 2 weeks say it even stronger, that an ICD should never be installed as a sports enabling strategy. Meaning that's the only reason we're doing it is just throwing it in for a safety blanket, and that safety blanket can be for either the family or for the installer. And at least historically, it's been more often than not the installers, laying a safety blanket than the families. But that can be a long conversation that we have, and we'll say, let's chew on this a bit, because
I really, really don't think we need one. I think we're great without one. And I share them our experience. And then they say, well, it kind of seems like maybe we really don't need one, do we? I was kind of thinking had to, so we can help them get to that comfort. Yeah.
There are obviously a lot of socioeconomic barriers in getting folks to be centers of excellence or they're able to make decisions. How do you capture those folks in your outcome that aren't able to get that information, aren't able to understand the shared decision?
Yeah, and that's one of this great question of, perhaps we have a unique socioeconomic collection who get to Mayo, but I can tell you that those who came, these restored athletes, they came from all walks of life. So these aren't just the wealthy who flew to Mayo. So these are as poor as they can be. So we do see them, but there's probably a skewing of socioeconomic status that gets to have that discussion and gets to say, well, I don't like what I've seen in my child, let's fly. So it's there, but not as completely skewed as one might think. But here's where I think Orca is going to really help, because Orca is all comers, and they just need to have the connecting physician, and we need to make sure the physician community is aware of Orca so that they can get these patients and families self-enrolled so we can track them. But the barrier issue, I definitely hear the point, and I'm not sure what else we can do to help that, smooth that, if you will, but it's not quite as dramatic as what it might feel at first blush. Yeah.
Thanks for the talk. I had a question about your caveat number 5 about the organizations and the colleges and little leagues, and how have their resistance or receptiveness evolved in time, and has this evolution of guidelines found its way outside of sports to physically demanding occupations like the military?
Oh, I love that question. You must know what we're working on. So this is a great question of how has it been received. So I would just, in our experience, we have almost no problem to return them to Little League, middle school, high school. That's almost, if we support it, we provide it, the school says just tell us what we need to know. We have almost no problem, meaning our return to sport percentage of success is near 100% at Division II, Division III sport. It's 50-50 at Division I. So, and you can picture why. Everything is risk aversion, and everything has to do with university memory. So if there was an athlete who collapsed on their university, that university is very reluctant to return somebody else, especially if that athlete's death garnered any attention on ESPN. So I tell all of my Division I bound athletes, never sign until it's been provisionally run up the pole through the team physician, the university lawyer, and you've been approved. I've had too many Division I athletes arrive and have their scholarship maintained, but then be told you're never playing here. And then they're doing the portal. And so we just prep them for that. Now, the professional league is next level complex. And so then it's all, how well is the professional society's players association lawyered up, and how well is the league itself lawyered up. And so it's just a very complex, experience. And the tactical athlete, so we have a guideline that's in the brew, is being made for exactly that. I had an hour consult yesterday with a special operations candidate trying to get him reinstated into the Marines. And that is really hard. But we have a document being advanced, and it'll probably come out within a year for what we're calling the tactical athlete. And that's the descriptor, because it's not just for the military, it's for law enforcement officers, it's for firefighters. I just got my first I think it's the first firefighter to my knowledge who got reinstated into his firefighting unit despite having a defibrillator. We had our first success with the FAA. in getting a commercial pilot reinstated with his defibrillator. So things are happening, but that's living in, I just got my first, so in anecdotal land. And so the tactical athlete experience, hopefully that's going to help the military. If you're in the front knocking on the door to get in, your heart better be really good right now. If you're in, and then you get found out, then it depends on what in your. So I have one of my patients with LQT2. He's in some branch of the Army that apparently none of us know its name. He won't tell me his name. And so he, by this time of having his LQT2 discovered, incidentally, he's now a multi-billion-dollar trained war machine, right? So they were like, can we keep him? And so the dynamics changed, but that's going to be the new document coming within the year. Yeah.
A lot of general pediatricians in the audience. Can you comment a little bit on ECG screening for QT intervals prior to psychiatric medications? It seems like it's a setup false positive. It's like running pregnancy tests on men. I mean, you're not going to find a whole lot of useful things there. So are these medications that dangerous in prolonged QT interval? And what should we use as a guideline? Like, okay, this one you should focus on a cardiologist. This is just upper limits of normal. I shouldn't order the, machine error aside.
Yeah, I think number one, I think that all humans should get evaluated for the possibility of long QT syndrome. So I am pro screening in the right setting. But this notion of pre-Ritalin screening, or pre-Concerta screening or whatever, I'm okay with it actually, because I think all people should be screened for a highly treatable, potentially lethal 1 in 2,000 condition. So I am an advocate for it, but we have a lot of problems with it. I think cut point is for pre-puberty. I view as flag criteria for let's check things out is greater than 460 before puberty, greater than 470 for males after puberty, greater than 480 for females after puberty. As something where that's pause worthy. That doesn't equal I found long QT syndrome. That actually translates to I now have not a 1 in 2,000 chance of long QT syndrome. I have a 1 in 20 chance of long QT syndrome. And I think that's worthy of a check. And that check could be as simple as, the ECG missed that by 30 milliseconds. And then they're now undone and unscreened or cleared. So if one's to do it, I would do it carefully like that. I'm not opposed to do it because I think all of us probably should have a one-time ECG to look at our QT interval. The worst time to get an ECG is actually in the emergency department 1 hour after a vasovagal faint, because the QT always reacts as a stress response, and you can get overdiagnosed with long QT syndrome very quickly. So be slow and hesitant in that scenario. Dr. Hartley.
Okay, we got 3 questions on the chat, but first we need to let the residents get back to the wards. So.
Well, great to see you. Thanks for coming, everyone.
Okay. Orca also includes, for example.
Yes. Yeah, all heart conditions are eligible for ORCA.
Okay. Then I'll let you read the other 2 questions here. Military service.
Yeah, we kind of touched on that with the military recruit, and that is, I tell Johnny and Sally if they want to enter the military that I'll do my absolute best to advocate for them, but that it's a long shot. So I think we have to be realistic with that.
One last one, and then everybody, if you can get the QR code and do a simple 1 question evaluation.
Yeah. So the last question is, how do we handle the family socioeconomic barrier to having the athlete having their own AED? Well, an automatic external defibrillator costs about $1,000 out of pocket. And for those who can't, there are a variety of nonprofit advocacy organizations that help families secure an AED. There's a company called LifeSure, which is a for-profit company, but they do all of the pitbull interference. with the insurance plans, and they have about a 90 to 95% success rate in getting the insurance company to nod their head, yes, we will provide an AED. So the barriers are falling down in terms of the ability to get a family, a person